she would have a strange, weird symptom, whatever, unusual.
Okay.
Maybe.
Sure.
And
Yeah.
they would say, oh, she's crazy. Send her to psych. And I hated that because I didn't think these women were crazy.
Sure. Yeah.
And the number of women that I've seen over my career that have come in thinking they're crazy, actually having been told by multiple people that they're crazy, that
Right.
we're not crazy, but they acted crazy because they kind of bought into it. Once they solved their problem, actually normalized and started to act like a normal human being and
Wow.
realized
Yeah.
they weren't crazy. And,
Yeah.
they cry, it's like, oh my God, somebody actually believed me. And,
Yeah.
anyway.
I mean, I think urinary pain is such a big problem. Bladder pain, pelvic pain, like we talked about. Why aren't those tests more standard? Like, why, if you have urinary pain and you do the culture, the standard stuff, it's negative for the 4 organisms or whatever. Like, why isn't there the next step? Is it because just doctors don't understand what to do with that data, or what's the sense? Hello and welcome back to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. I'm your host again today. My name is Dr. Scott Sherr, and it's a pleasure to be back with all of you. So today I had a really cool guest, very interesting topics about urogynecology, Dr. Linda Kiley. And I actually met Linda through the transcriptions company. She actually started using some of our products, methylene blue, cordyceps, and introimmune, and having some really great benefits. And when she told me what she did and how she was doing it, I was like, I need to have you on the podcast. This is great information that so many people don't know about. So here's a bio on Linda to get started. She's a graduate of University of California at Los Angeles, so UCLA School of Medicine, completed her residency in OBGYN at George Washington University in DC. She's a board-certified physician and subspecialist in OBGYN and urogynecology and reconstructive plastic or pelvic surgery with over 30 years of experience and decade of a really devoted time to minimally invasive surgical procedures for difficult gynecologic problems. And she's also very much involved in sort of the functional, natural methods of getting people better. She uses peptides, she uses off-label drugs. She's involved in the International Peptide Society, anti-aging medicine, A4M. She's been involved in that too. Extensive experience in treating people for hormonal disorders, menopausal symptoms, and really challenging patients overall. And she uses things like peptides, weight management, IV nutritional therapy, and very cool. She actually holds a 4th degree black belt in Taekwondo and is a master instructor. And we talked about that during a little bit of the podcast at the end as well. So in this podcast, we dove into some topics that I haven't really talked about a lot here, or really in my clinical practice. They don't have a huge amount of direct relevance, but I refer people over to people like Linda whenever I can. So we talked about many different things. We talked about pelvic pain, the musculoskeletal aspect of pelvic pain being the major thing that's underdiagnosed, and actually sending people over to pelvic therapy can be transformative for patients. And that's really amazing because most of these patients get written off and sent to psychiatrists. And there's a lot of musculoskeletal aspects of here. You can do a lot of good. Then we transitioned over to the bladder pain, bladder spasm. We talked about interstitial cystitis for a long period of time. Significant interest to me because this is actually a patient population that has the highest suicide rate and often gets sent to psych, but she does advanced testing like advanced urine cultures and finding bugs hiding in the bladder that regular doctors aren't seeing, and also looking at biofilms and how to break them up. She uses really cool ways of actually instilling various types of things like lidocaine, tobramycin, gentamicin, other kinds of antibiotics and other antimicrobials and also anti-inflammatories like steroids as well in the bladder to basically significantly help these patients. And she gave me a statistic or a thought that she actually thinks that about 90% or more of IC patients, interstitial cystitis patients, can be significantly helped by this kind of pattern or this kind of intervention and others. We also talked about gut dysbiosis. We talked about TMJ causing bladder pain and pelvic pain. So everything's connected, and Linda has a great way of bringing it all together here. So we also talked about Linda's inflammatory stack, her 3 ways to live smarter, not harder, and her black belt as well. So without further ado, please enjoy this episode with Dr. Linda Kiley. If you do like it, don't forget to like and subscribe below so you never miss an episode. Without further ado, here you go. Enjoy. Hi, Linda. It's nice to see you.
Nice to see you too, Scott.
Well, thanks for being here. You and I had a conversation around the transcriptions company. You were interested in some of the products, and you were telling me about your work as a urogynecologist and doing functional urogynecology. This is something that's not very common. And I thought it'd be great to have you on the podcast, kind of talk about your practice, talk about some very unique things that you see in clinical practice that are not well understood from outside of probably your clinical practice, and very few people that are like you. And so the first thing I wanted to talk about was pelvic pain. I know that you said that maybe three things that people come to see you oftentimes. One is pelvic pain, another is bladder issues, like the two main things, and then things around the bladder, and then HRT might be the third one, right? And so let's start off with the pelvis, the pelvic pain. Give me a little bit of a color there. Help me understand your frameworks. How do you think about this? How do people present? And then what are some of the ways that you kind of intervene and try to help here?
Well, the most important thing, I was taught this way back in medical school, is taking a good history. So one of the things that I like about my practice and my practice style is that I really just let my patients talk. I ask them questions, directed questions, but I really want to try to focus in on exactly what the pain is like, where it is, taking a good history, like a physician is supposed to do.
Sure. Yeah. A lost art. Yes.
Yeah, it seems. And that's one of the reasons why I can't do my initial evaluations remotely, because I need to not only interact with my patients like we're doing now, but I actually need to be in the room with them and I see their body language. And then I need to examine them, because the next part is physical examination. So, we were taught back in the day, history and physical. So pelvic pain can encompass so many things and is usually multifactorial. It may start out as one thing, but then become a number of other things. So, I try to identify, when did it start? Are there any things that are related to it, make it better, worse? The usual questions that one would ask. One of the things that I have found really seems to be biggest problem with pelvic pain is that because people are not thinking about the musculoskeletal system in the pelvis. The pelvis is a big, bones with a big bowl of muscles inside, right?
Yep.
And then all these connective tissues and nerves and all this stuff.
Yeah.
So, if you hurt your shoulder or you lift too much weight and your muscle gets sore, whatever, if it's your arm or your leg or whatever, you know what you did, right? You know why it hurts and stuff like that.
Right.
If you pull a muscle in your pelvis, it can manifest as urinary frequency, constipation, pain with intercourse, just pelvic pain, burning. There's so many. It can seem like a urinary tract infection. It can seem like a yeast infection. It can seem like just a ton of things. And sometimes it can happen concomitantly with other problems too. There can be infections there and stuff like that. But and sometimes the infection will incite the muscle spasm because, the nerves are irritated and then they get back and all of that. But so one of the things, I probably send at least 80% of my patients for pelvic therapy. And I have a cadre of pelvic therapists that I trust, that I know what to do. They're not going to make them do squeezing exercises or put biofeedback or stimulators or anything. I don't, that's not what it's about at all. And that's the other misconception I think a lot of people have. They think of pelvic therapy as Kegel exercises and biofeedback and strengthening. And there's this crazy chair that is being sold. And I'm not going to say the brand name, but don't buy a chair for incontinence. That's all I have to say. That's not what you need. An actual person with training who can also evaluate and then provide the right kind of therapy so that you're not, if you pulled your muscle lifting weight, you wouldn't go back and lift a heavier weight more times, but that's basically what's happening when you're trying to squeeze these muscles that are already in spasm. So, my job is to explain that and then get them to somebody who can actually work with them properly and get them out of pain. And the percentage of patients who respond well is extremely high. At least 80% of my patients that I send for pelvic therapy come back saying, wow, you were right. I'm amazed. I wasn't expecting to get better, but I'm so much better, so.
Is it one of the things with pelvic therapy is that probably depends on the person, but giving a sense of the kinds of things that you're sending over to pelvic therapy, how long it takes them to get better. So is it something that people will get better very quickly typically, or is it, I mean, obviously it's going to depend on the situation, but what's your general feel for that?
Um, Interestingly, I've had patients, I had one lady who had been in pain for 30 years, literally,
Wow.
um, and never been sent for pelvic therapy. I mean, her quality of life was horrible, 30 years, and she was better in a month. I mean, like
Wow.
almost completely pain free. She needed to continue pelvic therapy, like, intermittently,
Right.
but
Yeah.
she made
Maintenance. Yeah.
massive progress really quickly. I have some patients who have so many other factors. If you have scoliosis, you have, back issues that are chronic, and you have, other types of things that feed into this, you may not get as much better as quickly, but you almost always are going to get a significant improvement. And it may take more time, and it may take time to just figure out all the different moving parts to it. Because, I mean, I've had patients with TMJ who had pelvic spasm, so they needed
Really?
to work out the TMJ. Yeah, yeah, it's kind of
Wow.
interesting. So you never know where it's going to
So,
come from.
so what you're saying here, Linda, just to kind of break this down, is that pelvic pain, musculoskeletal etiologies are vastly misdiagnosed, or not even thought about, is what it's come down to.
Absolutely true. Um, and, unfortunately, I also sometimes see patients being referred for pelvic therapy um, to the wrong kind of therapy.
Okay.
There's all different levels of training. And so somebody who hasn't really been trained to deal with myofascial spasm, because that's basically what we're talking
Okay.
about. But, and puts them on a program of squeezing or, stimulation or whatever, that patient's not going to get better with that person. So I have to trust the therapist that I know that they're going to do what needs to be done with this patient. But I'm sorry, I guess I got off on a tangent, but yes, it's
And that's good.
woefully
That's good. Yeah.
undiagnosed, and it
Yeah.
often, if they do get sent for therapy, if they don't get sent to the right person, they may not get better. And I've seen it also where they say, oh yeah, I did therapy, it didn't help me at all, and I'm like, well, what therapy did you have? Who
Yeah.
did you see? What did they do?
Yeah. So maybe you can break down some of those types of therapy you mentioned, sort of like myofascial therapy as being one of them. What are the major sort of forks in the road where you're like, okay, you need this type of therapy, you need this type of therapy? Like, do you do that kind of assessment, or is it
I
somebody you send them to somebody for that assessment?
I do the assessment initially. So
Hmm.
what I do is basically I look for, um, you know, depending upon the history and all that stuff, I'll check for, hypersensitivity to the nerves. I'll check for reflexes, and then I'll check for muscle spasm and tenderness in the pelvis. So I do a vaginal exam and a rectal exam, and I check all the muscles, and I go one by one, face of the
Wow.
clock, basically hit
Yeah.
all
Yeah.
the
Yeah.
muscles and ask them, and I'll press lightly. And if they say that's uncomfortable or ow, I mean, sometimes I have them jump off the table and I'm barely touching them.
Sure. Sure. Sure.
And so that's spasm. So I tell them,
Gotcha.
okay, you're having spasm, and I'll write on my referral where I found the spasm. So,
Okay.
I'll give them a written referral to a pelvic therapist, and I'll say, you need to see the therapist. I'm not going to give you the types of exercises. I mean, I have a YouTube channel called the Holistic Urogynecologist, and I did a little exercise video one time of like stretching and things like that, just because I know there are people out there who can't get to a pelvic therapist who knows what they're doing. And so I didn't, there's a lot that's missed by not being able to do internal work, and pelvic
Sure.
therapists are trained to do internal work, but or a good
So they
one
go
is.
inside. They go inside the vagina. They go inside the rectum, and they're working
Yes.
on
Yes.
the muscles while you're doing various types
Yes.
of things, typically, right? So,
Yep.
like, what would that look like? So you're doing certain sort of like bearing down while somebody's working on part of like the vaginal muscles or something like that, or
So generally speaking, there's a lot of breathing exercise that gets done. You'd be
okay.
amazed. I don't, or maybe you already know this, at how many people do not know how to belly breathe, and they
Mm-hmm.
don't breathe normally. If you don't breathe normally and you're breathing just with your chest, you're not oxygenating yourself well. Your muscles are not moving the way they're supposed to. Your diaphragm's not working the way it's supposed to. That can disrupt how your gut functions too. I mean, it's not just your
For
microbiome,
sure.
you know.
Sure.
So, breathing, teaching them how to breathe is a really big part of pelvic therapy, interestingly.
Mm. I'm not
And
surprised. Yeah.
if I have somebody who and I'm evaluating and I'm seeing that, when I ask them to breathe, and all I get is, the chest movement and stuff. I go, okay, here's what I want you to do. I want you to go home, lay on your stomach and breathe. You can't chest breathe laying on your stomach.
Very
So
difficult to do. Yeah.
yeah, I mean, I guess you could, but it's not so easy. So it's not natural. So anyway, I leave the nuts and bolts to the pelvic therapist.
Sure.
When they come back, I ask them, what did you do? Especially if they're not getting better, well, what kind of things did you do? What did they do with you? How did they, all of that kind of stuff. Who did you see? And if there's something that doesn't add up, I might actually send them to someone different.
Okay.
Or I might say, okay, well, let me reassess and let's see if there's something I'm missing. You're not getting better. What else could it be? And so, always backtrack. And clearly, inflammatory disorders, fibromyalgia. I mean, women with fibromyalgia will often have myofascial pelvic pain too.
Makes sense. Yeah.
Fibromyalgia, trigger points, right?
Right.
So they need pelvic therapy, but they also need all of the other, the mitochondrial support and the energetics and the inflammation reduction. And, we have to go into that. And then we go to the microbiome. And, so then we start digging into, the other stuff. And that's really fun. I like doing that stuff.
Pardon the interruption. This episode is brought to you by Health Optimization Medicine and Practice Association, a nonprofit organization training practitioners how to optimize health rather than treat disease. For this episode, check out our chronobiology module. Several times, Dr. Linda talked about circadian rhythms, sleep, and inflammation. So you got to check out this module. It's a great way to learn how to optimize sleep in our patients from a cellular perspective, looking at hormones, looking at neurotransmitters, looking at micronutrients and everything else as well. So check it out at homehope.org and save 10% on this module or any module of the Essential Certification by using code POD10 at checkout. Now back to the show.
It's very rewarding.
It absolutely is. And so when did you decide in clinical practice to start adding in some of the more integrative functional kinds of things? Was it something that you because as a practitioner working in the conventional world, it's not that easy to start doing this kind of thing. Were there a couple of patients that you saw early on that kind of gave you this idea, or was it additional experience in different ways that kind of made you say, okay, like I'm going to start doing more the sort of functional integrative route, and from there maybe talk about a little bit like what your workup might be in somebody that was coming in as well.
Sure.
Yeah.
Well, yeah. So I got started with this out of frustration because, so urogynecologists typically we're surgeons, right?
Yes.
Gynecology and urogynecology is considered a surgical specialty. Urogynecology and reconstructive pelvic surgery is the name of the subspecialty. So, and as a surgeon, when you're trained, one of the things that you get told is, a chance to cut is a chance to cure and all that. And I always loved surgery. I have good hand-eye coordination. I'm a musician since I was 5. I've always loved fixing things, but I like fixing things not only with my hands. I like fixing things with my brain too. So when things didn't go as I expected, and I knew I was missing something, that I can't deal with that. That's just not, that doesn't sit well with my nature. I'm not the kind of person to go, I don't know, go see someone else. I can't do that. I might say, you might want to get a consult with someone else, but then I want to figure out what it is I'm missing and why I didn't solve this problem for them or help them solve this problem. So, I've always believed that the body wants to heal itself. That's something that I believe since, before medical school. And always had some level of, non-traditional. I mean, I was going to a chiropractor when I was a kid when I hurt my back. So, I learned a little bit about alternative medicine and stuff.
Sure.
So I was a little more open-minded, I guess, than some of my colleagues to some of the more esoteric things in medicine. And as I learned about, I learned more about hormone management. We were taught a very basic way to do it that's very lackadaisical, in my opinion. I learned more about that. I started learning about peptides, and before I went to medical school, I did a master's degree in cell and molecular biology. We spent all this time, this was a long time ago, but we spent all this time on DNA and cellular processes and all these things and the cell fine structure, and, all this great stuff, the mitochondria and the endoplasmic reticulum and all these great things. And I got to medical school and they're like, yeah,
Yeah.
yeah. This is what a
You learn
cell
it, then
looks
you
like.
forget it.
This is
Yeah.
what
Yeah.
Hodgkin's looks like on a slide, and stuff. And it's like, okay, well, that's what the cell looks like. What's going on inside the cell? We didn't talk about that too much. So
Understood.
anyway,
Yeah.
kind
Yeah.
of gradually getting into, I learned about low-dose naltrexone, and I learned about some like more esoteric things, and then it just kept me digging. I heard about A4M, so I took some courses there, and that led me to peptides, and it just kind of kept going. And the more I learn, the more I do, and the more things I could fix. Like people would get better and be like, oh, that's great, I can do this now. And so it was a gradual thing, but it was primarily born of frustration of
Yeah.
not being able to fix things in the traditional way and realizing that it was falling short and not giving my patients what they deserved. So,
Yeah. I get it. Well, I appreciate that context. And I think a lot of us, a lot of people in the world of integrative medicine, peptides, these kinds of things are getting there because they got frustrated with the conventional side of things and the lack of capacity to really do a lot outside of the small amounts that we can do to keep people from staying out of the hospital or
right.
recovering basically from a surgery and things like that.
Yeah.
As far as your framework now, when you work with people, Linda, and I do want to ask about the bladder in a minute too.
Sure.
But do you have a basic framework to use for everybody, or is it change? Like if you're coming in for like a functional integrative workup, are there some like main things that you do for everybody that comes through the door, or is it very individual depending on what they're coming in for?
It's really individual. I definitely do a lot of gut microbiome studies, but I don't do them on
Okay.
everyone.
Okay.
First of all, a really good one is expensive, and not everybody has the resources to do all of that. I mean, I have some patients who come in and say, like, do everything. I don't care. I don't care what it costs me. But most of them no. So empirically, I'll do some, I will do tests based on what I'm getting from them, whatever they've had before, what they haven't had that I think would be useful. I think it needs to be an individual thing. I don't have a
Sure.
protocol.
Sure.
I don't tend to follow protocols because everybody's different, you know?
Yeah, no, I think that's super important that we can't follow like the ER algorithm all the time if somebody comes in with chest pain, right? And this is actually where I want to get to bladder pain because,
Yeah.
like, let's talk about the bladder because you mentioned the gut microbiota. You talked a little bit about this with me when you and I chatted before regarding the presentation of bladder pain, discomfort. Tell me how you think about this, how people present. What have you found over the years as you work this up that's maybe surprising for people that are listening that they wouldn't think of, oh, this is causing, bladder pain or bladder discomfort?
Absolutely. It really runs the gamut. So the first thing I do is after I've taken their history and I do their exam,
Visual
I check
exam.
for
Yeah.
myofascial stuff. I mean, a huge percentage, if not 100%, it's really, really close, have myofascial component of that. So I
I see.
know pretty much
Yep.
they're going to go for pelvic therapy. That may not be their only problem. So I do a very highly specific type of urinary evaluation. So I have them usually on, if there's a question about how they're emptying or how well they empty, I'll have them empty and then I'll check up post-void residual using an
Mhm.
8 French catheter. So a really tiny one. I tell it's like a cocktail straw. It's really small.
Yeah.
But the reason I do that is there's data. There's actually papers that show, especially for women, not so much for men, but for women, having them pee in a cup is a really bad way to do a urine culture and urinalysis because there's so much contamination.
Right.
So I want a pure specimen so that I can send that off. So I get a catheterized specimen. I see what their post-void residual is when that's appropriate. And I use uh, a specialized lab to do the urine cultures
Mm.
because there are a couple of, I use Pathnostics. There's a lot of people will use Microgen. Um, I've used both, but I generally stay with Pathnostics. And
Why is it
so
necessary? Why is it necessary to do a specialized lab for urine culture?
because Quest or LabCorp does a very basic thing. And, they say they do an advanced culture, but I've never been able to get them to do it
Okay.
ever. So the idea here is like a basic culture that you'll get in a routine lab is going to be, they're going to take 1 cc and they're going to plate that on agar. And if anything grows in that after 24 hours, then they're going to identify it and do the whole thing. But, you know, if you don't get something to grow on that medium, let's say you have ureaplasma or mycoplasma or actinotignum chaliae or
I don't know
one
that
of
one.
those
Interesting.
other,
Okay.
yeah. There's a
Yeah,
bunch of
that's,
weird organisms like that.
I don't know. Tignum. That's an interesting one.
Yeah,
Okay.
yeah.
Yeah.
There's
Yeah.
it's had a number of different names, but there are a lot of weird bacteria and other organisms, even viruses, uh, fungi. I mean, especially in diabetics or borderline diabetics. I found, fungal infections. That's not going to show up on the standard. It just won't. So
So they
sending it to
culturing it with these other labs? What are they doing? Are they doing genetics or the DNA or what are they doing?
they do PCR, and then they'll once they've identified an organism, then they'll go out and they'll do sensitivities.
Got
So
it. Okay.
they do the PCR for the broad spectrum thing to find, do they find anything? And then after they find something, then they go further. It's one of the things I like about some of these labs. They do extra testing so that you're not just left with, well, we didn't find anything. Well, we found something, or we might have found something. We're going to look at a little further, or here's the sensitivity, and it's a real sensitivity profile. It's not just based on data. It's actually this organism was sensitive to these antibiotics.
Wait, hold on a second. You're saying that LabCorp and Quest are just doing the sensitivities based on data rather than
No,
actually doing?
no. They do
Okay.
culture and sensitivities,
Yeah.
but if you're only likely to find the big four,
Okay.
E.
I see.
coli, Enterococcus, Proteus,
Klebsiella,
and
yeah.
Klebsiella.
Yeah.
What about all those other ones? I mean, if I find a ureaplasma, there are some resistant ureaplasma organisms. I need to know, can I treat them with, doxycycline, or do I have to use lidocaine, or, et cetera. So,
Gotcha. Yeah.
so my job is to and I tell them this, I don't use standard labs for some of the things I do because you came to me for an answer and you already did the standard lab and get an answer. So, it's the whole definition of insanity, right?
Right. Of
Doing
course.
the same thing
Yeah.
over and trying to get a different. So,
Yeah.
yeah.
When you
So
do these advanced cultures on people, Linda, do you find that everybody has something growing at this point, or is it not that common? Only do you find it's like much more specified in the sense of how you can interpret them?
it's not unusual for me to find something like mycoplasma or ureaplasma or a weird other organism, and particularly in older patients who have compromised immune systems. It's not unusual for me to find something that's not in the spectrum of stuff that's typically cultured out. So, but I get a lot of negative cultures too, but that's okay. I mean, I'm okay with that. And the other thing is that, sometimes I'll find a patient that I suspect has a biofilm, and biofilms are notoriously difficult to culture out. So even if I get a negative culture, if everything they're telling me in their history and everything else I'm seeing, and especially they have some weird things in their UA, but they're not culturing out, I'll say, I think you have a biofilm. I think we need to look at it this way and see if, I'm going to believe your symptoms because you're telling me what you're having, and I don't think you're crazy. I mean, one of the things that used to make me crazy as a med student was I would go present a case to my resident, and it would be something weird. She would have a strange, weird symptom, whatever, unusual.
Okay.
Maybe.
Sure.
And they would say, oh, she's crazy. Send her to psych. And I hated that because I didn't think these women were crazy.
Sure. Yeah.
And the number of women that I've seen over my career that have come in thinking they're crazy, actually having been told by multiple people that they're crazy, that were not crazy, but they acted crazy because they kind of bought into it. Once they solved their problem, actually normalized and started to act like a normal human being and realized they weren't crazy. And, they cry. It's like, oh my God, somebody actually believed me. And,
Yeah. I mean, I think urinary pain is such a big problem. Bladder pain, pelvic pain, like we talked about. Why aren't those tests more standard? Like, why, if you have urinary pain and you do the culture, the standard stuff, it's negative for the four organisms or whatever. Like, why isn't there the next step? Is it because just doctors don't understand what to do with that data, or what's the sense you have there?
It may be a combination of things. There are a lot of things, insurance and labs, although most of these specialty labs have some level of insurance, agreements going on. but some doctors just don't want to be bothered by like doing that because it's an extra hassle. You have to have an extra kit. You have to have some,
Right. You have to have a catheter. Like it's not just like you're
yeah,
taking like a urine sample from the
right,
office,
right.
right?
Like
Yeah.
here's a Dixie cup, go pee it, I mean, but yeah,
Mm.
it's really, I think some of them don't know. I think some of them just don't think it's practical for them. Sometimes you're tied into a lab. One of the things that I
Mm.
had a problem with back when I was in corporate medicine, that didn't last, was they wanted me to use the lab that they had the agreements with.
Of
And I
course.
was like,
Yeah.
but they don't do what I want, so I'm not going to use them. And that did not make me popular.
Did not make you popular. Yes. He did not meet their metrics. Yes. I know.
Nope.
Yeah.
So,
Yeah.
but yeah, I
So
think
this is,
it's
yeah,
like
this is,
that.
I think it's so interesting, right? Because the biofilm piece is a big one. I've heard a number of people recently. I was speaking to a lady that specializes in interstitial cystitis, and she was telling me all about, a lot of these bugs can actually hide in biofilms, and that you don't know about it until you start breaking them up. And you do the urine cultures afterwards, and you can see all this stuff. Like, what are like from a biofilm perspective? What are the things you typically would use to try to? Is that a framework that you think about too in similar ways, or how
Oh
do you
yeah,
address? Yeah.
yeah. I mean, I've done methylene blue. I'll do like some of the general biofilm busters. I do bladder installations. In fact, that's something that I started
Hmm.
years ago out of desperation.
Hmm.
And
What do you
and
what do you put in there?
um, well, I have different cocktails depending on the patient, but the most
Hmm.
common one is usually lidocaine, heparin, triamcinolone, and gentamicin with a little
Whoa.
bicarb. So,
Where'd you come up with that?
there was a paper.
That's super.
I read the
Can,
paper.
can you rattle all those off again for me, please? There's
Yes,
lidocaine, gentamicin. What else?
lidocaine, heparin, triamcinolone, gentamicin, and bicarbonate.
Can
Just
you
to
just kind of go over why each of those, just for
okay.
people that? I mean, I think it's awesome. That's really interesting. Yeah.
Yeah, it's actually been really great. I mean, I've had patients who responded unbelievably well to this and had just get periodic treatments, after the initial set,
Yeah.
or just come back, oh, it's been a year. I'm kind of having symptoms. I need to do it again. Some who come every week. It's like, this is how I'm going to live for the rest of my life. It works. I'm happy, whatever. So, um, so interestingly, I had one patient who had this chronic UTI thing that I tried everything. I could not get a handle in. I knew she had a biofilm, and I couldn't keep giving her oral antibiotics. She was allergic to half the things, and
Sure.
so I found a paper on tobramycin, and then I found something on gentamicin. I was like, well, get gentamicin, and then I found another thing on lidocaine, heparin, and then the triamcinolone. And there are papers that say triamcinolone is not necessary, and papers that say works, and it's worked for me. I'm not taking it out. I know it's expensive, but
Sure.
so reducing inflammation with the triamcinolone. Lidocaine has a number of properties. I mean, I will use prilocaine on occasion, especially if someone's sensitive to lidocaine. I haven't
Okay.
switched over to it, although I know that there are some interesting data on prilocaine. But really, to relieve pain initially, that's part of
Hmm.
it. Just give them some initial pain relief.
Sure. Yeah.
And then it seems to have some, augmenting properties with the other things. And then heparin obviously is to, open up kind of the channels, if you will, uh,
So you're
it
breaking
just,
up platelet aggregation,
yeah, yeah. I mean,
kind of thing.
interestingly, heparin and penicin are related to one another. There's some similarities.
Hmm.
And so I think that it does have some anti-inflammatory properties as well.
Hmm.
So it's, and you don't need a lot. Different people who use these have different cocktails that, proportions and stuff. And then the triamcinolone obviously is, strictly inflammation. The
Sure.
antibiotic, if I can open up these channels with these other things and I can get the antibiotic in there, hopefully, gentamicin is usually pretty good because they haven't been exposed to it.
Sure. Yeah. It's
It's
not an antibiotic
cheap.
used very often anymore. Yeah.
Yeah. It's cheap.
Yeah. And
I
it's
mean,
relatively safe, I would imagine, in the bladder compared to orally
yeah.
or IV.
Yeah,
Yeah.
typically, I mean, you're not, you're not really absorbing a significant amount of it. So
Mm-hmm.
unlikely to have any blood levels. One of the reasons I resorted to it also is like, I'm not trying to destroy your gut microbiome at the same time. So if I
Right,
can
right,
really
right.
get it
Yeah.
into the bladder, there's not going to be that much that's going to get to the rest of the system. So hopefully I'm not going to be killing off your microbes in your gut.
Mm-hmm.
So
So
it's,
you
yeah.
instill it with like a small catheter, like that you were describing, and you have to do like a full, cystoscopy and things like that. No.
No. We just use
Okay.
a 14 French catheter, like in and out cath kind of thing,
Mm-hmm. Yeah. Yeah.
with a little syringe. So there's usually about 30 cc's or so, depending on what we're doing. And so it's not too much for, even a really, I mean, interstitial cystitis is a spectrum. I've seen everything from more milder case where it seems to be
Mm-hmm.
related to, chronic infection kind of thing, to so severe with the Hunter ulcers and scarring and, stuff like that, that the bladder capacity due to scarring and fibrosis is down
Mm.
to like 30 cc's. I had a patient who came in who had been given multiple hydrodistensions, which is one of those old-timey traditional treatments for interstitial cystitis that I'm not a big fan of. Every now and then I might do one, but I don't do it very often.
What is that
Um,
procedure? What is that? Just extend, like
that needs
blowing
to
out
be
the
done under
bladder?
anesthesia. So basically,
Okay.
it's a cystoscopy, and then you over inflate the bladder,
Got it.
and
Yeah.
then you leave it like that for about a minute or two, not too long, and then wash it out. And
Got it.
that
Okay.
will show you these inflammatory. Usually you get these cascading bleeding areas, and you'll see
Mm.
ulcerations and stuff like that. Those are Hunter ulcers. So you can see there's a really bad inflammatory condition
Mm.
here. But I've
Yeah.
seen patients who had a bladder capacity of 30 cc's.
Wow.
That's rare, fortunately. Um, but, putting 30 cc's in somebody's bladder, usually they can tolerate. I tell them, hold it as long as you can. Try to hold it at least an hour, but hold it as long as you can. And then pee it out. Don't worry about it. So, yeah, 30 cc's in the bladder is usually something that just about anyone can tolerate, even with minuscule amount of capacity. So I tell them to hold it as long as they can, at least an hour. I try to do that at least a minimum of an hour. They can go
Mm.
longer, go for
Even
it.
better.
Keep
Yeah.
it in, keep it in as long as you can. And then I'll look, depending on what I'm trying to do, I'll say, let's do this every day for a week, or sometimes even 2 weeks, depending on what, it is we're trying to get at. Or I'll do it, a couple times a week. Let's see how you do. Let's see how your first response is. Come back in a couple days. Let's try it again. And if they come back and say, wow, I had like 24 hours of just, I felt great, then I feel vindicated that, okay, we're getting to it. So we just need to do this. So I kind of have them do a package of,
Sure.
recurring ones. And so that's one way, you
Right.
know, um, I use low-dose naltrexone or ketotifen. I use
Mm.
I use peptides. Depending upon what I think the underlying issue is, like I'll use the thymosin or BPC. Especially if there's a gut component to this, and almost
Yeah.
everybody with IC has IBS or
Yeah.
some inflammatory.
That's what I was going to ask you next. It's like, so I see interstitial cystitis, right? So talk about the gut component to this that you see oftentimes. What do you typically see present, and how is addressing that affect your ability to treat the IC in this capacity?
Well, so there's some interesting data showing that first of all, there is a bladder microbiome. Uh, the fallacy that the bladder is a sterile environment is a fallacy. It's been
Yes,
proven false.
there's very few sterile places in our body. I think that
Right.
they don't think they really
Exactly.
exist, right? So yeah.
So one of the things that has been found in some of these elegant studies is that women who have overactive bladder, if you want to call it that, and who have other kinds of urinary dysfunction tend to have a dysbiosis in the bladder.
Mm.
And so, I feel that the gut and the bladder go hand in hand. And so most of the time they will have some sort of IBS symptom, whether it's just constipation, diarrhea, bloating, reflux. It's something like that. Sometimes it's really bad and they're like, oh my God, my gut is the worst. And sometimes it's just like, yeah, not that bad. I mean, yeah, sometimes I'm constipated. Sometimes,
Yeah, sure.
but once I establish that connection and we start talking about it, I tell them, I think that it might be well for us to spend some time on your gut because inflammation starts in the gut. And that's, if once you've got a leaky gut, because everybody's heard leaky gut at some point, I think. So once you've got that leakiness, right, that's inflammation leaking over into your body. Well, where is it going to go? It's going to go to your brain. It's going to go to your bladder. It's going to, other
Bladder's close
parts of your
proximity.
body.
Yeah.
Yeah. So we need to make sure that we have your gut working properly so that we can address your bladder. And yeah, I'm not forgetting about your bladder. I'm definitely going to address that. But we got to do something about your gut too if we really want to get you better. If all I do is focus on one little thing for you, I'm going to miss the big picture. The big picture is it's your whole body that's got a problem. That's just manifesting in one spot.
Right.
But if there's all these other things, and once we start delving and I start asking questions and we start talking about it, we start getting into these other things and the light bulb goes on and they're like, oh, these are all related to one another.
Yeah.
And, sometimes it's Lyme or chronic EBV or chronic herpes. I mean, how's your sleep? What are you sleeping? Oh, no, I have horrible sleep. I can't sleep at all. I take sleep medication.
Yeah.
So that's hence the holistic,
Yes, exactly.
functional,
And that's the thing. Like, and I love the way you describe that because there's so many factors at play, and then for some reason, you are manifesting symptoms specifically in this area, and that's why you're seeing me. But if I just try to address what's happening in this specific area without looking at the bigger picture, like your sleep or your stress or your gut function, you're going to miss the forest from the trees, and they might get better for a short period of time. But long term, those symptoms are going to come back. And I'm sure you've seen that time and time again.
Absolutely. Absolutely. So, yeah, I try to impress upon them. My goal is to give them better quality of life so that everything gets better. And we're not just going to sit in this one little space because they have a urologist, they have a gastroenterologist, they have a, cardiologist,
every
a
ologist,
neurologist, psychiatrist, whatever.
Totally.
They have all these different people. And one of the things that's unfortunate, there are some, but there are not a lot of holistic gastroenterologists.
No,
all I want to do is scope you. Look here, look there. And, I didn't see anything. It looks great. I don't see, I don't see anything wrong. It's like, well, but they're still having all these dysfunctional problems. So then we do the gut microbiome study and I found, amoebas and weird parasites and horrible dysbiosis, zonulin levels up, the wazoo, protected up, MMP9, all these crazy things. And I'm like, okay, let's do a little work here and see if we can get this thing straightened out. And we'll keep working on your bladder.
Sure.
And we'll work on your sleep and we'll work on, and
I get it.
It's fun. Yeah.
And this is actually, it's interesting because I was involved and I still am in hyperbaric oxygen therapy for many years. And it's a great tool and technology. And I get people to come in initially. I remember I have migraines. I want to use hyperbaric therapy. And initially I'm like, yeah, let's put you in the chamber, see how you do. Right. And then maybe they got better. Maybe they didn't, but their symptoms would always come back. Right. Because it's not like it was fixing was actually underlying. Just like if you fix their bladder, but they still have significant dysbiosis, you're still going to get that coming back at some point.
Right.
And then, one of the things I was just curious about your answer to this question. I was thinking about as you were talking, Linda. I know that interstitial cystitis has the highest suicide rate of any condition, I think, of any medical condition, which is crazy. I mean, what is your sense of the percentage of those people that have it that likely have the capacity to have significant improvement that are walking around with it now? You think it's 90%? Do you think it's 50%? Or what do you think from your experience?
At least 90. I mean,
at least 90%.
Yeah. I've had one patient in my career who came in, it was very long standing for her. And she was the one with the 30 cc capacity. Her husband had installed a toilet in their van so that she could, and she would just sleep on the toilet. I mean,
Jesus,
and she came to me. And at that point, I said, I don't know. I mean, your bladder is scarred down now. You may actually need to consider a cystectomy.
Yeah, sure. Yeah.
But she was miserable. It was horrible. So she needed radical treatment, something more than I would be doing. That's not a procedure that I do.
Right.
But I don't think there's a single person who can't be helped. Can we completely eradicate it? I mean, one of the things I've been doing lately too is genomic studies on people, and um,
Okay.
genomic studies on people, and looking at their hotspots and their detoxification and their inflammation and all of this other stuff, and that's really opened a lot of doors to okay, we can. I think it's even better than food sensitivities, because I think food sensitivities change over time.
Sure.
I don't know that they are, with the exception of maybe celiac disease. I think other things tend to be more mutable and have a lot to do with how the immune system is sampling and sending information to, in the gut, into the body. So I don't think that food sensitivities necessarily all stay the same. So I don't just want to take people off, all these foods.
Sure. Sure.
I really want to kind of come to the other side of it of where's the inflammation coming from and how can we bring that down? And yeah, sure, we're probably going to have to avoid some foods. You're going to have to back off on a few things for a while, but maybe not forever. And if we can get this other stuff under control and get your dysbiosis fixed and all that, probably going to be able to eat more things. Probably going to have less inflammation and less pain. But I think by doing that, the likelihood is that the vast majority of IT patients will be better. Will they completely better? Will they be cured? Well, there's so many factors.
Sure.
Maybe not,
Right.
I mean, I tell people.
With significant improvements. You see most across the board.
Chronic conditions are chronic for a reason.
Pardon the interruption. This episode is brought to you by Transcriptions, makers of precision-dosed, physician-formulated, and pharmaceutical-grade formulas in the form of a buccal troche. For this episode, check out our Just Blue. This is pure pharmaceutical-grade USP methylene blue, 16 milligrams. This helps with energy, detoxification, inflammation, endurance. It'll help with jet lag, going on airplanes and being pressurized to 6,000 or 8,000 feet and being low oxygen up there. So check it out at transcriptions.com and save 10% on your order by using code POD10 at checkout. Now back to the show. Right. And they kind of take a life of their own over time as well as a result of that. But over 90% think it has significant improvements. And that's a big deal because it's one of the most painful and most challenging conditions out there to treat and to also to live with. I mean, that's why the suicide rates are so high for this particular condition. And it's, it's so interesting how this multifactorial approach, this approach where you have multiple things that you're doing at the same time really can have a huge impact. One of the other conditions that I see a lot, I used to see a lot when I was in training, that was sent into psych, is endometriosis, right? Which is another one. So do you kind of see it in the same framework here as you do for IC and for bladder pain or for pelvic pain too?
Yes. So I have this list of things that I consider to be related to one another. So endometriosis, because I did a lot of that before I did the other. I did a lot of gynecology before I really got into urogynecology.
Mm-hmm.
I tended to really, because again, endometriosis is one of those things that is woefully underdiagnosed, undertreated, poorly understood.
Yep.
Pelvic pain. So anyway, endometriosis, interstitial cystitis, irritable bowel syndrome, or whatever, inflammatory bowel, however you want to call it, migraine headaches, fibromyalgia, long COVID, or, post-viral syndrome. I consider those all to be related to one another. The etiology may be a little different, but the underlying problem is still inflammation. It's a generalized inflammation. It's manifesting in a particular way, but a lot of times these will go together. I see and endometriosis, or endometriosis and IBS, and you see it all the time. And so you have to kind of, first of all, the most important thing that a doctor can do is validate the patient and say, I believe, I understand you have these symptoms, and they're not weird.
Right.
You're not weird. You're not crazy. There's, yes, there's really something wrong with you. And yes, it's affecting your quality of life. let's figure out what it is. I mean, like, yeah, I was having a conversation with someone I'm close to not that long ago who's been having some health problems. And she just said, you know, sometimes when I stand up, I get so dizzy, I have to sit back down. I black out. I go, oh, you have POTS syndrome? And it was like this light bulb. Her entire life changed with just that sentence. Because nobody, no gastroenterologist, internal medicine, nobody else had said a word like that or even tested or, done anything about it. It was just like a simple statement, like this
Yeah. Yeah.
thought in passing kind of things.
Right.
Like,
Yeah.
oh, yeah, I know what that is.
Yeah. Yeah. It's amazing. I mean, I
So,
think you're right in the sense that there's so much that sort of underlies the base of inflammation, right? In the sense that, like, there's a lot of things that can cause inflammation, but in the end, there's inflammation. So obviously, you want to try to find out the cause of the inflammation as much as you can, whether it's an infection or if it's, there's some significant mitochondrial or sort of nutrient deficiencies and things like that. Like, as far as like not personalized, but more of like an inflammatory or anti-inflammatory stack. What are the main things that you use there? You mentioned already LDN, for example, and ketotifen as two things that you use. Like, what are your kind of your base like anti-inflammatory things that you typically use in most patients?
So I'm very fond of BPC 157 because it
Okay.
can be taken orally, and I do the gut type a lot. So the BPC can be combo.
Mm-hmm. Mm-hmm.
So I put a lot of patients on that because it tends to be very well tolerated,
Mm-hmm.
and it often makes a difference. It may not be a big difference. I mean, in some people it makes a huge difference, in some just a little. But I'll do that.
Mm-hmm.
And depending upon I might. There are some supplements that I might go to, sulforaphane or DIM or turmeric, curcumin. Sometimes I use those things too. Of late, I've started using some cordyceps because
Oh,
I like
nice.
that. Yes, I like
Nice.
that.
I like that. The
Yeah.
cordycepin from Tromium, or like
Yes,
this.
I
Nice.
do. I do
Nice.
like
Nice.
it. Yeah. Yeah. I've been using it. I like it for the deep sleep thing. So
It does increase deep sleep. Yes, that's true.
yeah, it's
Yeah.
nice, which is to me, that's like one of the most critical things about reducing inflammation is getting the deep sleep.
Yeah.
So,
That's a big
and
one.
then, yeah. And then the thymosin, I've had just tremendous success with the thymosin alpha 1, thymosin beta 4, in the properly chosen patient. And then depending upon what else, if there's mitochondrial dysfunction, you can't get MOTS-c anymore. SS31, if you can.
Right.
There are a lot of things you can't get anymore, so we're just sort of stuck with what we've got. But what we have is still pretty good. Doesn't work for everybody. And then, again, the right kind of probiotics, either empirically or if I could do a gut microbiome study, that, the sodium butyrate also help the gut.
Mm-hmm.
A lot of that inflammatory stuff on the gut. Zonulin and Lexinox. I've been using a lot more in Lexinox.
You have been using that. Okay, interesting. Yeah.
I like it. I like it. It seems to be really well tolerated. It's not expensive compared to some of the other stuff that we have.
Right.
And I think because it's well tolerated and not highly costly, it's easy to incorporate with other things that we do. And so usually I use a cocktail and I'll start, I usually start with kind of one or two things at a time. So often, depending on the patient and how bad it is and what I'm really thinking about, I'll start with like the oral BPC-107 or the peptides, and then Lexinox, lorazepatide, if I'm really thinking a lot of gut inflammation and, the permeability issue.
Yeah. What's your experience been with lorazepatide? Have you had good experience with that one?
Pretty much, yeah. I have some patients who are like, I'm never going
Gotcha.
Yeah.
So lorazepatide, for those people that don't know, maybe you can just describe what that is. I think that's a relatively new one.
So first of all, zonulin is something that's a normal substance in the gut that allows nutrients to pass through the gut lining into the body. So, we want to have some zonulin, But one of the things that seems to happen, and some people are much more susceptible, is
Mhm.
zonulin levels go really high. And so everything's getting through. The bacteria produce something called lipopolysaccharide, which is an
LPS. Yep.
inflammatory
Yep.
substance. And if you get a lot of that going across, you are going to create brain inflammation. It's going to hit wherever it's going to hit, cardiovascular system, the bladder, musculoskeletal. I mean, a lot of places that you can get it. So you don't want your zonulin levels to be through the roof. You want them to be normal. So lorazepam is a zonulin blocker, and it doesn't block it 100%. We're not trying to turn it on. We're just trying to turn it down.
Mm-hmm. Mm-hmm.
And usually I'll start by really turning it down, and then I'll kind of back off a little bit and, just give it a day, and then maybe intermittently cycle it, kind of thing. But initially I try to do like twice 2 doses a day, and
this
like
is oral,
really
correct? It's an oral peptide, right?
Yes, it's an oral one, which is really nice.
Right.
Yeah,
It's
that's
nice
the
for
other
people
thing is.
That's nice to be, yeah. And the Amlexinox, maybe you can just give people a quick description of what that is and what that does, if you know.
Sure. So Amlexinox, it was approved in this country as an eye drop for like allergy symptoms and stuff. In Japan, it's approved for use in asthma, but I think it gets used for a lot of other things. It's an orphan drug here because it wasn't popular enough. It didn't sell well. So the company that got the approval stopped making it, but we can get it compounded, and we can get it, orally. It is effective, and seems to really be beneficial for reducing inflammation in the gut, as well as, I've had patients say eczema got better taking it. And, eczema seems to go along with the inflammatory gut thing too.
Sure.
So it's interesting that I've seen that improve in some patients who were on Amlexinox. So,
cool.
because it's well tolerated, and because it's just also damping down some of that inflammation. And it seems to do it in a very nice way. I've become really fond of it.
I can tell. That's cool. Yeah. I mean, I don't have a lot of personal experience with it in my clients, but I do know I had Dr. Elizabeth Yurth on a podcast not too long ago, maybe about a year ago now, and we talked a lot about Amlexinox. We talked about some of the other orphan drugs that are out there, that she's using as well. So really cool stuff. But this has been a great, I think, overall conversation about like some really challenging conditions, like, bladder pain, pelvic pain, interstitial cystitis, endometriosis, IBS, dysbiosis, TMJ causing pelvic pain. And so it's kind of amazing to me that these resources aren't more available to people to think about. And so I'm really happy you're doing this kind of work and kind of bringing it out there and like getting more exposure so that, it's amazing to me. Like you also said to me, 90% of people with IC can get better, right? And like that's like not heard of in the medical world. In the conventional world, you have IC, you go to psych. Like that's what happens, right? And like there could be a component there, don't get me wrong, like where people have that psychosocial emotional piece, right? And like that needs to be addressed. But you see real changes by actually addressing the bladder, taking out those biofilms, doing the advanced urine cultures and all that stuff.
Absolutely. And just really believing the patient. I think one of the things that is the most therapeutic is the acknowledgement of the reality of the symptom and that they're not crazy. Once I acknowledge, yes, I understand you have this condition, and I have a number of things in my toolbox. I have a much bigger toolbox than I had, 10 years ago or certainly 20 years ago.
Sure.
And so I'm going to bring out as many things out of that toolbox for you as I can possibly come up with. And we will try to find something that gives you some relief. I can't promise you're not going to have flare-ups. This tends to be a chronic condition, but we will try to get to the bottom of it. And whatever it takes to give you a better quality of life, we're going to do that.
I love it. So we ask one last question for everybody on the podcast, Linda. And I love your emphasis on history and physical, by the way. It's like such a big deal because it's a lot. These are losing arts, right? I mean, I don't do many physicals anymore, but I still do a pretty good history. But I just want to say that before I get to the last question, which is we ask every guest on the podcast, what are 3 ways that all of us can live smarter, not harder? Meaning like, what can we do smarter and not work as hard to get the outcome, right? So it could be like, work 4 hours and take 4 hours off and then do another 4 hours, like whatever, like everybody's got all their crazy patterns and things like that. Or it could be things in health and wellness or in your life. So from everything that you can think of, like what are 3 ways that you feel like everybody can live a little bit smarter and a little bit less hard overall?
Okay, well, first of all, you have to find a physical activity you love to do.
Okay.
So I've been a martial artist for about 24 years. I just went today. I was there for an hour this morning. Um, it is part of my life, and I love doing it. I can't imagine not doing it. And I think everyone needs something like that. It doesn't have to be martial arts. I think martial arts are great because they do a lot,
A lot of it. Yeah, sure.
fast twitch muscle, weight bearing exercise,
It's got it all.
you
Yeah,
know,
totally.
mental, like the whole thing. And
You're
you
convincing me I need to
fight and
start
kick
this.
things.
Okay.
Yeah,
Yeah.
it's great. But anyway, so you have to find
Yeah.
a physical activity that you like to do.
That's beautiful. I like that. Yeah.
And then, everybody talks about work-life balance, and, there are different phases in your life where you're working more and you're not taking care of yourself as much because you're focusing more on your career and whatever, depending on what kind of career you have. We know what it's like in medicine. It's,
We do.
you give up a certain portion of your youth, and that's just what it is. But, find something that fulfills you, work that you enjoy, because we all need to work and feel needed.
Yeah.
We need
purpose,
to feel
right?
like
Yeah.
what we're doing.
Yeah.
We need to find purpose. I guess that's the word.
Yeah.
Is purpose. And, there are lots of data out there about how purpose is a primary driver of longevity. And when people lose their sense of purpose, that's when they start to die.
Yep.
So, that, find your purpose and pursue it, not to the extent that you're killing yourself, but maybe for the first 3 years when you're young and you can deal with it. If it's something that you really need to do like that, if it's your calling. I tell people who are interested in going into medicine, if it's your calling, do it. If it's not your calling, go into something else, finance, whatever.
Find
whatever.
something else. Yes, totally.
Yeah, do
That's
something
to say
else.
about surgeons too. If you don't love any other specialty, then be a surgeon. If you only love being a surgeon, but if you find anything else that you like almost as much, you should do that instead. That's what everybody told me in surgery.
It's funny because the advice that I got was a little bit. He said, it was one of my OB/GYN instructors, and he said, it's really easy to pick your specialty. Are you a surgeon or not? If you're a surgeon, then you have to do a surgical specialty because you won't be happy in a non-surgical specialty. If you're not a surgeon, don't do it. If you already know. You walked into the OR and one of two things happened. You went, yes. Or you went, and I went, yes. So that was it. I was a surgeon, and I did not go into medical school thinking I was going to do that. I thought I was going to go into family practice and, be Marcus Welby, actually Stephen Kiley, my last name was, and he rode a motorcycle, and
that was pretty cool. Yeah.
Neither here nor there.
Yeah. I love it. Yeah.
Okay.
So do you have a third one? Like a
third thing?
Yeah.
Be good to yourself. But by doing that, I mean, we know what's good for us. We know what kind of food is good for us. We know whether or not we should be drinking or, doing all these other things. We need to be good to ourselves. And that means, get the sleep that you need. I mean, you're not going to always get it. You're going to give it up for good reasons sometimes.
Sure.
But don't let that go. Do the right things for yourself, because that's going to really help you function when you're stressed out and when the chips are down and all that kind of stuff. So
I love it. Yeah. And that's something you figure out over time, right? It's not something you know typically when you're younger, but as you get older, you understand, the gut feeling is there for a reason, right? Like there's nerve endings in that, as we know. Well, Linda, this has been great. Where can people hear more about your work or learn about more of your practice or what you do?
Well, so I practice in Palm Beach Gardens, Florida. The name of my practice is Ultra Health and Wellness, but and I have a Facebook and an Instagram page, and so they could go on either Facebook or Instagram and look up Ultra Health and Wellness, or they could look up, drlindakiley.com. That's my website. And I'm not too hard to find. I actually have that YouTube channel that I haven't really added a lot to in a while because I,
I've heard of it. I've heard of it. Yeah. Yeah. Well, I think those are all great resources. And Linda, I really do appreciate you spending the time
Thank
with
you. Thanks
me,
for
with our
having me.
audience to discuss some of these more challenging topics. This is also very self-serving for me in the sense that like these are topics that I care a lot about that not a lot of people know about. And that there's great people to refer to like you to help. And I'm sure you have a cadre of other people that you know around the country. If people have issues, they could potentially reach out to you or your team, and they could potentially, find some people in their local areas. So, so
Yeah.
thank you for spending time with me today. And I'm glad you got your martial arts training in earlier.
Thanks a lot. Well, thank you for having me on. I love being able to spread the word because I feel like I don't want this to, die or retire with me. And at
Yeah,
some point I am going to retire. So I want people to know about this stuff. You know what I
no,
mean?
it's good. It's important. Yeah. Well, okay. Well, enjoy the rest of your day, and we'll talk
Thank
soon.
you.
Okay.
All right. Great. Thanks a lot.
Thanks so much for tuning in to another episode of the Smarter Not Harder podcast, where we give you 1 cent solutions to $64,000 questions. In this episode, Dr. Linda went through some amazing ways of really approaching some very difficult conditions: pelvic pain, bladder pain, interstitial cystitis, inflammatory stacks, dysbiosis, and much more. I learned a ton. I hope you did too. If you have these kinds of symptoms or have patients with these kinds of issues, refer them over. That's what I do all the time. Linda or her office may be able to help you if you're not in Florida, where she's located. So check it out. Really great information. So if you like this podcast, don't forget to like and subscribe below so you never miss an episode. And we'll see you next time on the Smarter Not Harder podcast.